Good morning. I am Dr. Obaid. To thank the organizers for giving me this opportunity to present my talk here. Today I'll be talking on ECGs in the ED, common and rare. The topic is a huge one, and since I'm restricted to 20 minutes, I'll be just going through 10 ECGs, and we'll discuss that in a little bit. All the ECGs that I've shown here, we'll do it as case scenarios. All the ECGs are simple, straightforward things that you routinely see in the ED. And with each ECG, there's one point that I want you to take home. So by the end of the talk, you should be getting at least 10 points. So we'll start with the 6 case scenarios. In the scenario 1, we have a 65-year-old male who presents with chest pain, and this is your ECG. Anybody would like to venture a guess or make a diagnosis? Okay, let me help you out. The rhythm is in sinus, the axis is normal, the rate, it's a sinus rhythm, axis is normal, but you can see tall R waves with ST depression and T inversion in one AVL V5, V6. Similarly, you have deep S waves in V1 to V3. This is suggestive of LVH, left ventricular hypertrophy. The point to be noted here is, in this particular ECG, we'll be discussing the differentials of T wave inversion. This is a common scenario that we see in the ED. Patients come with chest pain and they have a ECG with LVH. So how do you distinguish between the T inversion seen in myocardial ischemia with that of the T inversion seen in LVH? As you can see, these are the T inversions, and this is the T inversion in ischemia, whereas this is the T inversion in LVH. There are 3 differences which you will use to distinguish between the T inversions. One is that the limbs of the T wave are symmetrical in the case of ischemia, whereas it is asymmetrical in the case of LVH. Second, the T wave is deep in the case of ischemia, whereas in LVH, the T wave is not that deep. And the tip of the T wave is pointed in ischemia, whereas it is blunted in LVH. So those are the 3 changes. And a quick question, which precordial lead usually has the tallest R wave? Anybody wants to give it a try? Normally you would expect that because of the progression of the R waves, R wave keeps increasing in length from V1 to height from V1 to V6. But in reality it is V5 which is the tallest and not V6. The clinical significance of knowing this point is that V6, when it becomes equal to or taller than V5, is a corroborative evidence of LVH. This was the earlier ECG that I've shown. Here you can see that the R wave is tallest in V6, once again evidence of LVH. Coming to scenario 2, we have a 50-year-old male who comes with generalized weakness, and this is the ECG. Anybody wants to try? It's a simple, straightforward. All the ECGs are simple, straightforward ECGs. Is there a P wave? No. There's no P waves. And you can see a tall T wave, a tall pointed T wave, which makes the probable diagnosis of hyperkalemia. So one of the differentials for the tall T waves in hyperkalemia is, once again, the tall hyperacute T wave of myocardial ischemia. In hyperkalemia, these are the changes which are routinely seen. You have tall peak T waves with shortened QT interval, which is usually the earliest signs of hyperkalemia on ECG. Later on, you have progressive lengthening of the PR interval and QRS duration. P wave disappears, QRS widens, and finally you end up with the sine wave pattern. The differential diagnosis of tall T of hyperkalemia, like I said, includes, one is myocardial ischemia. There are other T wave differential diagnosis, but this is the most important and what we need to rule out in the ED. So once again, most people, this is hyperkalemia, and this is myocardial in ischemia. The tall T wave of hyperkalemia has 2 distinguishing points by which it can be used to distinguish it from myocardial ischemia. The first, and what is commonly known, is that there is a tall pointed T in hyperkalemia, and the T is not so pointed in the case of myocardial ischemia. The second point, which a lot of people fail to appreciate, is that the base is also as important as the tip. The base of the hyperkalemic ECG is generally narrow when compared to the base of that of ischemia. This is because in ischemia there is ST segment elevation, and because of the elevation the base also goes up, whereas in hyperkalemia there is no ST segment elevation. Coming to scenario 3, we have a 45-year-old male smoker who comes with chest pain, and this is your ECG. Okay, so you can see ST segment elevations from 1 in leads 1, 2, AVL, AVF, V2, V3, V4, V5 and V6. In addition, you can also see PR segment depression in 1, 2 and most of the precordial leads. And the rate is exactly at 100. The diagnosis is pericarditis. Pericarditis is important because the patient presents with chest pain and you have ST elevations seen on the ECG. Pericarditis, acute pericarditis undergoes, like the changes in MI, it has an evolution. The evolution of the pericarditis changes is that in stage 1, which takes place in the first few hours to couple of days, in that you have the PR segment depression along with the concave type of ST segment elevation. In stage 2, which usually occurs by the end of the first week, both the segments come back to the baseline. The PR segment comes back to the baseline as well as the ST segment comes back to the baseline, and the T wave is flat generally. Stage 3, what happens is the T starts to go into inversion. T becomes inverted, whereas in stage 4, it gets normalized. This usually takes several weeks, sometimes may not occur. This evolution of the ST segment, this evolution of the changes, ECG changes in pericarditis is important because you will need it as a differentiating factor from that of ischemia. The one important thing to be noted is the evolution of changes, ECG changes in pericarditis occurs in only 60% of the patients. 40% don't have these changes. So, like I said, you have a patient who comes with ST segment elevation and chest pain, and your differential diagnosis, most importantly, is usually the acute myocardial ischemia. Then you have something called the benign early repolarization, which again presents with the same picture and is commonly seen in the ED. Up to 15% of the patients coming to the ED have a benign early repolarization. And another differential diagnosis is pericarditis. Question is, how do you distinguish between the three? In acute myocardial ischemia, we can use all these factors. The ST segment elevation in acute myocardial ischemia is commonly convex upwards, whereas those in pericarditis and benign early repolarization is concave upwards. The distribution is territorial in the case of acute myocardial ischemia, whereas pericarditis and BER does not have territorial nature of ST segment elevation. Coming to the reciprocal changes, they can be seen in any of the leads in MI, whereas in pericarditis, reciprocal changes are limited to AVR and V1, whereas in BER, you don't expect any reciprocal changes. The evolution of ST segment changes takes place in both acute MI as well as in pericarditis, but never in BER. Acute MI, how do you distinguish between the two? That is the reason why I showed you the evolution earlier. In acute ischemia, the changes occurs in minutes. The evolution of the STT changes occurs in minutes, whereas in pericarditis, it takes place over days and weeks. Concurrent ST segment changes can occur in acute MI. For example, you can have an ST elevation with a concurrent T wave inversion in acute MI, whereas in pericarditis, generally you won't have ST segment elevation and T wave inversion at the same time. Once the ST comes down in the stage 2, then in the stage 3 you have the T inversion, whereas in BER you do not have concurrent T inversions generally. T waves are very tall in acute MI, whereas in pericarditis they may be normal or a little bit tall. BER is usually associated with peak tall waves. Pathological Q waves is commonly seen with acute MI but not with the other two. PR segment changes are seen in pericarditis, not commonly in acute MI, can be seen. BER is not associated with PR segment changes. QT prolongation is seen in acute MI but not with pericarditis or benign early repolarization. MI can be associated with any type of arrhythmias, whereas pericarditis is generally associated with sinus tachycardia, whereas BER is associated with lower rates, sinus bradycardia. Now, in most of the changes that we discussed earlier on, it is easy to distinguish acute MI from pericarditis and BER, but it's still, many of the features are common between BER and pericarditis. In such a case, how do you distinguish between the two? The site of the ST segment elevation is important because in pericarditis, almost all the patients will have changes in both the limb leads as well as in the chest leads, whereas in BER, in up to 50% of the cases, the ST segment elevation is restricted to the chest leads. PR depression and evolution of STT changes are seen only with pericarditis, whereas J-point notching, prominent J waves and notching are associated with BER. Then there is this ST segment elevation T wave amplitude ratio in V6, which is very important because this ratio has a 100% positive predictive value and a 100% negative predictive value for differentiating pericarditis from BER. If, as you can see, the basic concept is that if the ST segment is more than 25% of the amplitude of the T wave from the end of the PR segment, then it is pericarditis. This is an ECG showing benign early repolarization. You can see the notching here in these leads V1, V2, AVF, sorry, lead 2, lead 3, AVF, and beginning of the notching there in V5 and V6. In acute MI, you have the classical pattern with the reciprocal changes. This looks like an proximal RCA lesion. 4 quick questions, just coming back to the basics. The baseline of the ECG is not the PR segments, it is the TP segment. Causes, because PR segment can go up and down. What are the causes of PR segment depression? Like I said, one is pericarditis, the other is atrial infarction. Pericarditis associated with lower heart rates are usually seen with uremic pericarditis. Pericarditis not associated with typical ECG changes is once again uremic pericarditis and pericarditis due to hypothyroidism. Coming to scenario 4, we have a 65-year-old diabetic and smoker with complaints of typical chest pain. And this is the ECG. As you can see, there is a lot of diffuse ST segment depression and looks like and STEMI. Now, suppose the same patient comes with this ECG, you can see a lot of ST segment, huge ST segment STEMI basically in V2 to V5. There is a minimal ST segment elevation in 1 and AVL. Forget that for now, assume that it is normal. Now, the patient has come with 2 ECGs, one is NSTEMI and one is STEMI. Which is more dangerous? Which has a bad prognosis? Generally, the tendency is to think that when we see an ECG like this one, with huge tall STEMI, we run around and make sure the patient reaches the cath lab in another 15 to 20 minutes maximum. Whereas this ECG, when you see this ECG with a lot of diffuse changes, people tend to be a little bit relaxed. They think like it is NSTEMI and STEMI is more dangerous. But this is NSTEMI is STEMI has something like it has a minimum guarantee, whereas NSTEMI is a huge spectrum where it can have relatively good prognosis to extremely bad prognosis, even worse than STEMI. In this particular case, you can see the elevation in AVR and V1, which is indicative of a proximal LAD or bar LMCA lesion, whereas the ST elevation in V2 to V5 without much changes in the other limb leads is generally seen with distal LAD lesions. So, QRBB, that is one more thing that useful to know. QRBB in V1 is suggestive of LMCA bar proximal LAD lesion. But it has a worse prognosis because it's a proximal lesion, whereas the distal LAD has a bad prognosis. The learning point in this particular ECG was that NSTEMI can have a worse prognosis than STEMI. Coming to the 5th scenario, a 30-year-old male presents with palpitations. There's a lot of learning points in this particular ECG. One, there is tachycardia. Whenever you see, on the first look, you see a lot of complexes. It clicks that there is a tachycardia. Once you see the tachycardia, the next thing that you ask is it a narrow complex or is it a wide complex tachycardia? In this particular case, this ECG I have put to talk about QRS. The first thing is, if you eyeball the QRS duration, if you just suddenly look at it, it looks like a narrow complex QRS. But this is not a narrow complex QRS. The normal QRS, I want you to take back 4 points from this particular ECG. The normal QRS duration is 120 and more. Sorry, up to 120. The wide QRS is 120 and more. Many people have the misconception that wide QRS begins from 121. 120 is included in wide QRS. The normal is actually from 50 to 119. This is very important because many a time the QRS width will be exactly 120, and if you make a mistake of thinking that it is a narrow complex, you are basically distinguishing, missing a VT for a SVT or something like that. So the first learning point is that the QRS width is 120, wide QRS is 120 or more. Second is, where do you look for QRS width? You know that for P wave, if you want to look at P wave, you look at V1, lead 2 or V1. If you want to look for the U waves, you look for at the mid precordial leads. But where do you look for QRS? In QRS, there is no specific lead, but there are two things that you should look at. One, the QRS should have a definite beginning and should have a definite end. And in those leads which fulfills this criteria, it should be the widest. So the widest lead with a definite beginning and a definite end, that is the lead where you look at the QRS. The third point that I want to come across is the importance of picking this up, because you're going to miss a VT otherwise. The fourth thing is
5 minutes left.
Okay. The fourth thing is that this is okay. So we have established that this is a wide complex tachycardia. So you're differentiating now between VT and the rest of the differential diagnosis. Is there anything in the ECG which is suggestive of VT? Yes. You see the morphology, it's all the same, but in between there is a narrow complex. That is a capture beat which is strongly suggestive of VT. In addition to this, you can see that there are some dissociated P waves. There is a P wave here but none here, and then again you have one here, again you have a dissociated P wave. So this is definitely a VT. So what type of VT is this? You have an RBBB pattern with a left axis deviation, monomorphic sort of appearance with a with a relatively narrow QRS. This is something called a vesicular VT. It's a little bit rare, but all emergency physicians should know it because of two reasons. This can easily get misdiagnosed for an SVT with RBBB. The reason being, one, it looks the width of the vesicular VT can range from 100 to 140. 100 is actually in the narrow range. Second, it occurs in the group of patients in which you would expect SVT, young patients with structurally normal hearts. These are the learning points: the normal QRS duration, which lead to look for QRS, the importance of measuring QRS carefully, and existence of vesicular VT. Coming to scenario 6, you have a 30-year-old female who presents with palpitations. Is the rhythm regular? No, it is irregular. It is irregularly irregular, so brings up the possibility of AF. And in AF, what is the ventricular rate? The ventricular rate here is 300, whereas here it is 150. The QRS morphology is changing, the duration is changing. So all this points to AF with WPW. AF with WPW has 4 criteria. One is that it is irregularly irregular, a ventricular rate of more than 190. In AF, the atrial rate is from 350 to 600, but the ventricular rate never exceeds 180 because of the AV nodal delay. But if there is an accessory pathway like the bundle of Kent, the impulses will come down through that, and that will increase the rate to more than 190. QRS duration complexes will vary with morphology and duration, obviously, because it's coming down 2 pathways and going through 2 tracks. The axis will be stable. That is one way to distinguish it from VT. Why is this not VT? Because the axis is stable, unlike in VT. So the learning point in this particular ECG is that AV nodal blockers are contraindicated in patients with AF with WPW. Amiodarone is also preferably avoided. Coming to spotter ECGs, scenario 7.
2 minutes left.
60-year-old male with palpitations. This is just pattern recognition. What is this? A lot of people would answer Torsades D pointers. This is not Torsades D pointers. This is polymorphic VT. The point of bringing out this ECG is to differentiate the difference between the two. People tend to believe that the spindle shape appearance of the ECG makes it Torsades. Torsades is a type of polymorphic VT which has a prolonged QT interval. Unless you have a documented QT interval, you cannot call it Torsades. So this is actually polymorphic VT. I just wanted to differentiate the two. Scenario 8, a 60-year-old male with chest pain, and this is what you see in the precordial leads. You see an symmetrical tall T with an upsloping ST segment depression, with usually associated with AVR ST segment elevation. This is D. Winter's T waves. It has been described recently in 2008 and is found to be, it's seen in 2% of the acute LED occlusions, and it is now considered to be an ST segment elevation STEM equivalent. You see the depression here and the tall T waves with the AVR. Scenario 9, a 45-year-old female presents with fever, and on ECG, incidentally, this is found. What is this? Brugada type 2. The reason for putting this ECG is everybody knows the Brugada type 1. In the ED, just about everybody knows the Brugada type 1, but not many people are familiar with Brugada type 2. There were 3 types of Brugada, now there are only 2 types of Brugada. Type 1 is you have an ST segment elevation with a Coving type of ST segment elevation with a downsloping ST, and you have the inverted T wave. When you have a saddleback appearance, with either a biphasic T wave or an upright T wave, that's called the type 2 Brugada. There's a difference between Brugada pattern and Brugada syndrome. Brugada pattern is when you have an EC change without the clinical symptoms. If a patient presents with syncope, this becomes Brugada syndrome. The last ECG for today, 60-year-old male patient presents with chest pain, and this is seen as the mid-precordial leads. The patient had chest pain at home. By the time he came to the ED, there is no chest pain. Okay, so this is valence, biphasic T wave in the mid-precordial leads generally. There are 2 patterns. It can be biphasic, eventually becoming this thing. So the take-home message is always interpret the ECG in context. ACS, like Sir said yesterday, is a clinical diagnosis. It's not just ECG based. Just because the ECG is normal does not mean you can send a patient home with typical symptoms. And if you are going to pick one point from this presentation, I would rather it be this: always measure QRS duration carefully. Thank you.
A very nice presentation and very good elaboration of the ECG, and I would like to just add a few points. In LVH, actually the first ECG what you have showed, we can see most of the times in LVH there is, I don't know if the emergency physicians, it is better we can go with the criteria for LVH.
Yes.
So in that criteria there are many things, there are many types of criteria that are there for LVH. So if you can see in the ECG that which is presented here, so here we can see, yeah, it's a very good ECG, and sometimes we will look for acute MI because there is some ST coving even that is seen in V2 and V3. There are some changes in the lateral leads, so that we may think that probably this patient is going to have ST elevation MI, and we can go for serial ECGs if we don't diagnose LVH in the first ECG. So whenever we are looking for LVH, we have to see that there is some left atrial enlargement, there is left axis deviation, lead 1 and AVL. In AVL, if the size of the R wave is more than 11, then it is more likely that the patient is having LVH.